I'm Tim Deere from West Virginia. I want to welcome you, and I'll turn it over to my friend Dawood Syed. Dawood.
Yeah, thanks, Tim. It's really an honor and a pleasure to be able to share another evening with everyone tonight, those that are joining us live and those that'll watch the recording that'll be made available tomorrow. But I really think that this debate format has really taken off. I've had, I'd probably say hundreds of people since we've started doing these last year say, we really love this format, and we really do think that this actually helps shape clinical practice. And I think that's really great to hear. And I think, we're trying to stay true to that, even though when you do have debates, some personal opinions are going to obviously sneak in that and biases. But, the people that we bring in, the folks are really data driven. They've written a lot of the papers on a lot of the subjects we're going to be talking about. So this is going to go far beyond just anecdotal opinions. This is really going to be a lot of facts and evidence. But, people can be on both sides of things, and there really doesn't have to be a wrong person, but it's good to see two viewpoints. So, but really the most important thing I want to say is that even though my Chiefs didn't make it into the Super Bowl this year, I'm still representing KC in the house. We'll be back next year. We did take out Christian's Buffalo Bills though.
Oh man, that was a tough one.
Krish.
Yeah. Thanks, Tim. Thanks, Dawood. Really looking forward to hosting this with Erica too. I think this is meant to be fun. So in typical football fashion, I'm going to call out my picks for the debates today. I'm going with Sheth, Beal, Strand, and Escobar. I'm going to see how right I am or not. I think they've come very well prepared. It's going to be a tough battle, but I think all four of them are on my side of winners tonight. We'll see how that goes, but turn it over to Erica.
Well, thank you, Krish, and welcome everybody. This is exciting, and just a little color commentary. I can tell you some of these teams have been doing a lot of advanced preparation, and so really is going to depend on who thinks that they're really warmed up and ready to hit the field. So I'll be excited to see how this debate ends up panning out. We'll all circle back at halftime to do some analysis. And I want to thank everybody who's here participating with us, and those we're recording this as well. So there's an opportunity to circle back and review some of the finer points later on, or to get friends who missed it tonight to tune in for things as well. But with that, we'll be ready to dive into our first debate. Dawood, are you there?
I'm here.
Yes.
Yeah, I'm here. I'll just give a quick thank you to our sponsors, Vertos, Stratus, SPR, and Corner Lock. Let's go to the next slide, and we'll start in the first quarter. Let's play ball. Our moderators are going to be Dr. Deere and Dr. Meacham.
All right, welcome to the show, everyone. So we are very excited to start the first and probably the best quarter with a very good debate by in between Dr. Alexander Escobar and Dr. Ajay Anthony. And we're going to be talking about, is decompression with a mild procedure enough for patients for greater than 2.5 millimeters hypertrophied ligamentum flavum? And we're going to start out, I think, is it with Dr. Escobar who's starting with this? Is that he's on the left? And,
I'm on standby waiting for that timer, so we play by the rules.
All right. And so when the timer starts, he's going to go. And here we go.
While decompression with a mild procedure being enough for patients, not parties, it's not only enough, it really should be the first line. And all I want to say to everyone out there tonight, thank you for letting me join you. We've all witnessed a big transformation in the field of pain medicine, from only palliative therapies to now definitive treatment options for a number of specific diagnoses. And none more common or specific than lumbar spinal stenosis, which has now become like a household term. It's been reported that up to 13% of our population is affected with this. And with the increasing prevalence of symptomatic spinal stenosis, there's an emergence of treatment options that are available. And while many of these minimally invasive treatment options demonstrate safety, efficacy, and cost effectiveness, the superiority of these newer procedures over traditional decompression surgery is still unclear. What I would like to make clear here tonight is that the mild procedure should be the first line therapy when patients present with symptomatic lumbar spinal stenosis and identifiable ligamentum flavum hypertrophy of 2.5 millimeters or greater. Following the evidence in our space is now more important than ever, and the mild procedure has plenty of it. With 2 level 1 studies that support safety, efficacy, and durability of the procedure, the Midas Encore study had demonstrated that there is no difference in safety as compared to an ESI. And really, when we think about complication rates, comparing a therapy to an injection that we do routinely and showing no difference in safety is huge. In addition, 94% of patients presented with comorbid disease on radiographic findings. But I do want to be clear that it's our duty to correlate symptomatology with radiographic findings and not just treat the image. And the presence of neuroforaminal narrowing doesn't imply radiculopathy. In addition, the motion study highlighted the functional improvements with 0 device-related adverse events. And I can't stress that enough, 0, which makes the mild procedure not only the first-line therapy, but really the safest one. Less than 8% of the mild patients in the motion study required further intervention. And this closely resembles my clinical practice, which demonstrates roughly 10% going on to further treatment options if the mild procedure is not enough. At our recent Innovation Summit, Dr. Stats gave us a little insight into Medicare claims data that showed the mild procedure had the lowest rate of harm and subsequent procedures versus traditional decompression surgeries, plus or minus implantable hardware. It's clear that the risk-benefit analysis of decompressive treatments, the mild benefits outweigh the risks of other more invasive procedures, and affirms that mild procedure should really be the first line when there's evidence of ligamentum flavum hypertrophy. Look for the ligament, treat the source of the problem, and leave nothing behind.
All right, Dr. Anthony, are you ready?
I am. I think that's a tough one to follow, my good friend and colleague, Dr. Escobar, but I think I will give it a shot. I see the clock is running. The only thing leaving me with a little bit of confidence is the fact that Christian picked against me. So I feel pretty good about that. And, when we talk about this question, I think it's important to maybe take a step back and ask ourselves, is this even the right question? Because I think this is too broad a question to be able to answer with a blanket yes or no statement. The question itself is, is the procedure to decompress the ligamentum flavum with greater than 2.5 millimeters hypertrophy enough for patients with lumbar spinal stenosis? And that patient with lumbar spinal stenosis can be a variable presentation. That patient may have central ligamentum flavum hypertrophy and central canal stenosis type symptoms. And in that case, this may be the best and first line option for those patients. There may be other patients with more of a peripheral column stenosis, being a unilateral radicular type symptomatology that gets better with sitting or flexion, where the pathology, when correlated to advanced imaging like an MRI, may be in the neural foramen or the lateral recess. What we don't have evidence for is using this particular procedure to decompress the ligamentum flavum to treat symptomatic lateral recess or neuroforaminal stenosis causing unilateral symptoms. What we do have with this procedure is something that offers perhaps one of the best risk-benefit profiles in our entire field. As you mentioned, Dr. Escobar, we do have safety and efficacy evidence for this procedure that is not a surgical procedure, but more like an injection type procedure that has minimal recovery time. But when answering a yes or no question, I don't believe that this question is specific enough. This doesn't take into account things like spondylolisthesis. This doesn't take into account things like stability when looking at flexion extension films. And I think in a more 10,000 foot view perspective, as interventional pain physicians delve into procedures that alter the structure of the spine, it's important to take on other biomechanical considerations and maybe speak the same language as spine surgeons. And for a spine surgeon, all patients with lumbar spinal stenosis are not created equal, and therefore one blanket therapy for all of those patients cannot apply. I think as we kind of move into procedures to treat lumbar spinal stenosis and work and collaborate more with other colleagues of other disciplines like spine surgery, I think it's imperative that we speak the same language, that we look at the risk-benefit profiles for each of these procedures, and in further steps, come up with maybe collaborative guidelines that involve spine surgery, interventional pain, and we build that body of evidence to not only look at safety and efficacy, but other biomechanical things that we're starting to look at now. So to answer the question, a simple yes or no isn't going to cut it here.
Great kickoff by both of you. We each now get 1 minute apiece to rebut the other before we have 5 minutes of moderated questions. So Dr. Escobar, you get to go first. 1 minute rebuttal.
It's hard to rebuttal Dr. Anthony's comments about, the specificity of the diagnosis and really looking at the symptomatology. I would absolutely agree that when there's presence of radiculopathy that's dermatomal, that has a positive SLR on exam, your treatment options may vary. However, what I would suggest is that when patients develop neurogenic claudication that is clearly improved with forward flexion, and you do identify ligamentum flavum hypertrophy, it behooves you not to treat this first. I think with the plethora of options that we have, our goal and intention is to never think about the next intervention. We want to make sure that the patient has the best possible outcome with the first step procedure. And with limits to access to injection therapies, we really should be considering mild when there's proven ligamentum flavum hypertrophy after the first epidural steroid injection, regardless of the efficacy.
Dr. Anthony, your floor, my friend.
Well, I'm going to agree on one thing, and I think that when looking at efficacy in terms of durability compared to something like an epidural steroid injection, we're talking about this as the next line option after an epidural steroid injection for ligamentum flavum hypertrophy when correlated with the symptoms and the MRI. What I will push back on a little bit is I think we need further evidence to perhaps make subcategories of these LSS patients, right? Looking at grade 1 spondylolisthesis and perhaps the variability within that, looking at maybe less than 3 millimeters of flexion extension translation, but those patients with borderline findings on those imaging, those patients may not all have the same outcome. And I think maybe subcategorizing these patients as we build that body of evidence would help us make these decisions further.
Wow, great points by both of you. Dr. Meacham, you have the first question of our 5 minute Q&A.
Thanks. So really fantastic to hear both of your perspectives. And I think that I agree with both of you. I think that it's really important to consider the risks and benefits when you're not sure, when it's multifactorial, and when you pull the trigger on that and what the risk profile is if you're going to make that choice. Can you talk about what it is that would keep you from deciding to do this in a patient where there are multiple reasons for them to have stenosis in addition to their hypertrophy?
I'll take that first question. I really find that the efficacy of this procedure is in the hands of the interventionalist. Unlike other modalities that are very specific to patients' anatomical features, the mild procedure is an art that can be performed on really a plethora of patients that demonstrate ligamentum flavum hypertrophy. As the access can vary and we have streamlined techniques to minimize procedural time, there's really not a patient that I can't gain access to the interlaminar space to provide an effective decompression with the least invasive option. While with other modalities, I found in regards to spondylolisthesis, the evidence or the incidence of migration of implantable therapies seems to lose efficacy and durability over time. And also my surgical colleagues in my area find to not want to remove these devices once they're implanted and defer to the implanter. So that's something to take into consideration when you are now looking at an implantable therapy is your ecosystem and your community-based practices.
So let me ask a follow-up question to that. And Jay, this is for you. Every day when I get a stenosis patient coming to see me now, many times coming to see me trying to avoid larger surgeries, we have the option of doing mild. We have the option of doing some form of spacer, some form of posterior, maybe fusion. How much spondylolisthesis do you really think is a contraindication to any of these procedures? And what is someone on the borderline there? What are you looking for?
Yeah, so I think, with indirect decompression, with ligament decompression with the mild procedure, I think we have very solid evidence that grade 1 spondylolisthesis, which are stable is an acceptable procedure, acceptable patient for these procedures. The key is to work up that stability with proper flexion extension films and to rule out greater than 3 millimeters of translation. Indirectly to your question, that patient comes into my office every day as well. I think everyone watching the webinar tonight would agree that, it's a common patient who's looking at perhaps options other than direct open surgical decompression. And with the mild procedure, along with other tools in our toolbox, I think we have a very, very good chance to help that patient and a very low chance to hurt them. And I think that makes a very easy clinical decision.
All right, Dr. Meacham, you have time for, I think, 2 more questions from us, or maybe 3.
And so in terms of figuring out how to explain this to the patient, and how would you explain to the patient what it is that you're going to do and why?
Yeah, I try to simplify these terms to patients. And one thing, I had the benefit of training at the Cleveland Clinic, was really being at the mecca of where, the mild procedure was showcased. And I saw a number of patients who would come in for the social follow-up to really say how good they were doing after 2-3 years following a mild procedure. So I like to use spine models. I like to demonstrate to the patient that there's an area that's compressing the canal. As a kink straw, we want to remove that kink and leave nothing behind. And I really have never seen a procedure with such minimal to zero procedural discomfort with such prolonged durability. And so I can confidently tell my patients that the procedural pain that they're going to experience following this technique is minimal to zero, which I can't give confidence to with the other advanced therapies that I offer.
So, I think, Kate asked you a great question, Alex. Now I want to go to Jay for a follow-up question on that. He trained at the Cleveland Clinic. I don't know where you trained, but he threw that out there. So I'm not sure if that was a little bit of the first punch thrown here. You have about a minute left. Tell me something that Dr. Escobar said that's incorrect tonight, something you disagree with, and I'll ask him to do the same. And then Dr. Meacham will get the last word.
Oh, gosh. Well, first of all, I'm surprised it took, about 10 minutes here for him to mention that he trained at the Cleveland Clinic. But I do think that, one thing is to not minimize potential risks of any procedure, right? Any procedure comes with risks, even an epidural steroid injection, even a, medial branch block. And I do think that it's important to, even though we have this awesome, risk benefit profile and body of safety evidence, to acknowledge that these procedures do come with risks. And in the hands of maybe an untrained physician who hasn't had enough experience looking at their own MRIs and kind of understanding the procedural anatomy, these aren't something to be taken lightly. So I just add, the proper training and the proper understanding of spinal anatomy is imperative to doing these procedures safely.
Dr. Meacham,
I really can't say that Dr. Anthony said anything incorrect, but I would like to highlight that grade 1 spondylolisthesis was included in all of the studies that demonstrated efficacy and durability with the mild procedure. And what I found is in presence of grade 1 spondylolisthesis, understanding that there's no instability with flexion extension, it really behooves you to utilize a therapy that will not pose risk of migration and then prevent further access should it be necessary. So I would say that ultimately, when you consider a patient for a mild procedure, it is a procedure you can utilize with confidence following that first initial ESI. And really what we're going to find in our space is that we're forced to offer more definitive care for patients when we're limited in the access for effective epidural injections. So I used to be of the believer if they would get a couple months of relief with an ESI, I would continue that therapy. And I've changed that thought primarily because of my outcomes. And I've stood behind this procedure while offering many techniques. I find that really this can be the definitive care that may give motivation to a patient who was previously fairly reluctant for further options, and really just continue the care of that patient for your next step should they require it. So this is really first line, and all of the other things that may be possible are only considered after a true failure therapy exists at 3 to 6 months.
All right, cool. And so thanks for that, passionate. So it's time to field a Q&A question if we have time. and then we can wrap it up.
We have about 30 seconds, I believe.
Mhm.
Quarter win.
So that might be a little challenging. Does anybody have a burning question from where we are? Okay, here we go. Multi-level stenosis with HLF. I often complete 2-level milds with a single incision technique. I find 3 levels to be challenging due to the angle needed and size of the patients, if possible. What is everyone's experience? Is HLF and more than a number of levels change the thought process? I think that what we're going to do is we're going to start tabling those questions and follow up. There's also, how do you address the possible risk of a chance for a dural tear? So for the sake of time, we're going to make sure to follow up on those questions and wrap up this session on time. And thank you all for a really, really fantastic start. And we'll make sure to follow up on those questions and any other ones that have developed from it. Great start, guys.
Yeah, that was a great first quarter. We'll come up, we'll be responding to questions either later tonight in the conclusions or during the online on our website. So with that, that's in a Q1. We'll bring on the debaters for quarter number 2. Great job, everyone.
Well, good evening, everyone, and welcome. My name is Stan Golovac, along with Kaz Amer-Delfrin, great friend of mine, colleague, and an exceptional physician in this space. I'd like to introduce 2 of my esteemed colleagues and friends who are going to debate tonight. Professor Natalie Strand, Doc du jour of 13 years at the Mayo Clinic, and none other than Mark Malinowski, who's 14 years at Ohio Health. So as we would want to kick this off in the right manner, and Michael Buffer would say, hey team, let's get ready to rumble. So we should start off by asking Natalie, who's going to be the pro at this. She's extremely experienced, well-versed, understanding as to what radio frequency does and offers, but we want to ask her a specific question that Kaz and I have formulated. So Natalie, is anatomy of concern when using a device, tool, instrument like the Nimbus versus a conventional needle when it comes to performing lumbar radio frequency ablation?
You're not going to let me give my 3-minute pro talk?
No, you should do your 3 minutes first, and then we'll go into the questions. So Natalie, totally do that first.
I want some time back on my timer, team. I see what you're doing. You're trying to throw it towards the other doc. I see.
I think he's trying to rig this quarter.
This is rigged. Okay. That is an excellent question, and I will answer it. But I'm going to start with what I wanted to start with. Is that okay, guys?
Yes, absolutely.
Go for it, Natalie.
Go, go, go.
All right. So, you know, where I practice, we have this sign on the wall that says the needs of the patient come first. And I think that's applicable to all of us in pain medicine, especially in current times. This is like a renaissance of technology, which is why we have to have these debates, because, you know, at some point we have to really advocate for our patients and accept new technologies, but we also want to make sure that we stay safe, that we avoid any pitfalls that might be coming. So, you know, when just talking about Nimbus versus standard cannula radiofrequency ablation in the lumbar space, which is, you know, the main topic for tonight, there are several factors that we need to consider. We need to consider safety, efficacy, our patient's experience, the cost, the total time of fluoro exposure, the total time it takes to do the procedure. And I think most of us can agree on the ideal landmarks on fluoroscopy, but we really have to be honest about the inherent challenge posed by anatomical variations. These are tiny nerve targets. One of the ways we try to overcome this anatomic variation that we all know about is by increasing lesion size. So that is not a new concept. Traditionally, what have we done to do this? We try to make a lesion larger by using a larger diameter RF needle, like a 16 gauge, maybe doing multiple lesions, maybe doing bipolar RF, parallel lesions, using probes with an internally irrigated cooled tip. But as we know, there are several limitations with those approaches. So what Nimbus did was they developed their needle with this in mind, to consistently, efficiently, and safely produce a lesion of such a size and shape that predictable ablations can be accomplished using an easily mastered technique. So we want to talk about data. Obviously, I'm a fan, but we want to talk about the data. So Dr. Scott Bainbridge did a study, and these results were presented at the International Spine Intervention Society in 2015. The nimbus lesion was evaluated with EMG as well as MRI post-procedure. The lesion size is 600 millimeters cubed. It is huge. Post-procedure EMG showed that the targets were successfully ablated in 88% of patients, so we know it is effective. At the same meeting, Dr. Burnham presented 25 patients who underwent nimbus RF procedure and compared them to the own patient's prior double lesion technique. Efficacy was similar, but the procedure time and the fluoro exposure were significantly improved in the nimbus group. So, we know it's effective, we know it's faster, we know it makes a large lesion. Is it better? This, I think, is very interesting. Dr. Mark Russo recently published an original article detailing a new technique to denervate the facet joint pain generator while maintaining normal multifidus function. One of the big things with RFA is we don't want to denervate the multifidus, especially in our younger patients. So this approach, using the coaxial technique with the nimbus needle, may allow us to spare the multifidus muscle, which would be phenomenal. My last point is, what do other experts say? I turned to the consensus guidelines published in Regional Anesthesia and Pain Medicine in 2020, led by Dr. Steve Cohen. And what they suggested was, with limited size lesions, the tolerable margin of error is very small. They suggested that placing an electrode perpendicular to the target would result in a larger lesion, more horizontal space, creating a greater area of coverage to ensure ablation of the target nerve. They also said that decreasing technical failure by increasing the lesion size should be a relatively non-controversial endeavor that most people can agree on. So in summary, I'll say this. The nimbus needle creates a bigger lesion. It does it faster than a double burn technique. It does it with less fluoro time. It's easier to master with a coaxial approach. We may be able to offer a multifidus sparing technique, and it's been shown to be as effective for as long. So really, I feel bad for my competitor here, because I think the only thing you're going to be able to say is that it might be a little bit more expensive. Well, I'll go back to the needs of the patient come first.
Wow, Dr. Strand, you laid down a very strong argument here. So let's give the ball to Dr. Malinowski. Dr. Malinowski, it's your turn. What say you?
I love it. I love it. You know what? Dr. Strand is right. Cost is important, and cost gets translated to the patient. Without a doubt. Certainly, we got to be cognizant, though, what we're talking about here. The things that I feel, and I want to first state thank you to Nimbus and Dr. Wright for sponsoring this segment. That should be said. But the thing we have going for us when we talk about traditional radiofrequency ablations, we have physics. We have data and safety and the longevity of it. We also have the technique that's also important. A lot of people talk about geometry of approach or size of lesion, but we forget about some of the basics. And I think that's important because there's a large variety of training programs and a large variety of ways people are being taught. But truthfully, sensory testing and motor testing is super important. The closer you are to that medial branch nerve, the more likely you're going to get capture of that nerve during lesioning. And let's face it, when we're talking about radiofrequency ablation, we have to recognize that the mechanism of action isn't necessarily how much nerve we destroy. It seems like we practice on common sense. There's a lot of validity to that. But in fact, we don't have a lot of pedigree research to really support what we're talking about. Traditional radiofrequency ablation is based on traditional physics as it relates to the lesion that's formed. The size of the lesion is formed by essentially the electrode size, the power of the energy delivered, the contact force applied to the target, as well as the cooling effect of the surrounding tissues. That's super important. As you have the energy travel from probe to capture point at the pad, the grounding pad, we have this dispersible annular energy being delivered to the tissue, which actually creates the thermal ablation in the first place. It's not the probe itself. So we have to be cognizant about the physics that we're talking about when we start manipulating the size of our probes or the geometry or the bipolarity versus monopolarity argument in terms of what is being delivered to the tissue. Ultimately, traditional radiofrequency ablation has level 1A data without a doubt. Nobody can question that whatsoever. And in fact, you can create a lesion with traditional radiofrequency ablation of approximately 360 millimeters. And the argument is, oh, well, we can capture a greater lesion size. Well, fine. The way you could do this approach traditionally is you ablate the tissue at 80 degrees for 90 seconds, but then you go ahead and rotate the needle 180 degrees. Let's talk about that Russo study in the last 15 seconds. Russo study was a study that proved that it was non-inferior, not superior to traditional radiofrequency ablation. And in fact, their time was only approximately 30 seconds less in total for lesioning when you compare it to traditional technique of RFA. Thank you.
That's excellent. Two very strong teams playing an excellent game in the second quarter here. We are all super excited, and we're going into the rebuttals. And just like any good football game, it's not really a game until we're in the fourth down and the quarterback throws a very long pass for a new first down 6 times in a row until the team wins. Natalie, the ball is in your court.
Well, thank you, Dr. Malinowski. I'll say this. Nobody's trying to say that we need to ablate a ton of extra tissue. I think what we're trying to say, and that we've already agreed on in the past, is that if you don't ablate the nerve, the patient won't get better. So how do we account for ablating the nerve and increasing our chances of catching that nerve? And one of the ways that we already try to do that is a double lesion technique or some of the other large lesion techniques we've discussed. So the question really is traditional double lesion technique better, faster, safer than a Nimbus needle technique? And I'll say this, there have been studies that show you can accomplish approximately 240 more ablations if you extrapolate the time out that it saves. And with that, you get 40% less fluoro time. So if it's as safe, as effective, you get 40% less fluoro, and you could do up to 240 more procedures in a year with that time saved. To me, that seems like a win all around.
Excellent. And Mark, I'm a small community doctor. I've been doing traditional radiofrequency most of my career. Help me validate that procedure for my patients and help me continue it. The rebuttal is yours.
Well, quite frankly, let's talk about what the selling point is of quicker and faster, right? So 100% agree with Natalie. I think Dr. Strand has great points, but let's go back to the physics. Let's talk about cost savings. Why don't we go ahead and traditionally we're looking at where we put the grounding pad compared to the needle. Why don't we move the grounding pad? That's a cost of 0. And what does that do? It creates a denser lesion at the point the closer you are to the actual delivery of energy. So you got an insulated needle. Unlikely you're going to thermally burn the skin because it's insulated. You can create a denser lesion by simply moving the pad. That'd be a great study in the future. What does that really look like rather than redesign a whole needle just for quote, safety and quickness?
Excellent. Thank you, Dr. Malinowski. Dr. Golovac, how about we get the first question for the teams?
Well, having done a few of these, as all of you know, I would think that Mark has brought up some interesting points. And Natalie, not to say that your strategy and your ways of performing RF ablation aren't to be respected, but I would think that being accurately placing the needle and using a very cost-effective needle is a way that I would side with my dear colleague, Mark Malinowski. I think that, from a time-saving reduction in fluoral time, Mark, help me to appreciate better the cost analysis when it comes to the value of what you can achieve with simply doing a standard, straightforward radiofrequency needle versus the style and performance that Natalie Strand likes to use with the Nimbus.
Well, from a cost standpoint, there's a big difference in radiofrequency needles. Time in the OR, that would be interesting to balance out. Not 100% certain, given that I've never been involved in an ASC personally, and I'm a hospital-based physician. But I would look at the pure, and I'm not so certain I'm buying the issue of saving on fluoro, especially when you can change to pulse fluoro. There's ways that you can get around not having to do lateral fluoro. And certainly you have sensory and motor testing, but simply the needle. And let's face it, when you change out a needle and you've got innovation going on in the space when it comes to these RF generators, most of these studies have ramp up times of 30 seconds or greater. Well, guess what? That doesn't even count anymore when you have the newer generators. And in addition to that, we have a needle that's not designed for that generator. So what's the cost when you have a complication, an electrochemical complication because you used a needle not paired with the proper generator?
Natalie, any defense there?
Absolutely. With all respect, Dr. Golovac, I think it's a misinterpretation to say that we're not accurate with anatomic placement with this. I'm exceedingly accurate with this, just as accurate with the other needle. In fact, more so because I'm not moving it after I've already numbed something that I can't test. So I'm exceedingly accurate, just accounting for the natural variability in human. The exercise will help me account for that. And cost isn't everything. I work in academics. I don't look at the cost of anything. So I'm going to throw that out for me personally. But I want my patient to have a good experience. I want the procedure to work. I don't want them to come back for another procedure that they don't need if this was effective. So I'm a huge fan of traditional ablation. I'm a huge fan of this. I just want whatever is going to be the best outcome for the patients, in my opinion. And in traditional opinion, we need a large lesion to accommodate that in the majority of our patients.
Excellent. So I've got a question for you all. We keep talking about the size of the lesion here, and there's been a lot of talk amongst all the key opinion leaders about how the bigger size of the lesion could potentially be more effective. It's not that radiofrequency, the way we've done it traditionally, has been ineffective. Why is it that the size of the lesion is coming into conversation so much right now? Dr. Malinowski?
Yeah, that's a great question. I think we have to look at what the mechanism we're talking about. So bigger can be better. It depends on what we're talking about. If we get a bigger lesion, theoretically, you got destruction of that axon. But, though, does that translate into more wall area degeneration at the contact point or at the sensory point? Who knows? That's never been studied. As a matter of fact, that's a difficult study because you probably have to do a lot of sectioning in animals and so forth, and electron microscopy just to prove that. But quite frankly, if you have a larger destruction, a larger lesion creating a larger destruction, who's to say you're not recruiting more Schwann cells and creating more an aggressive response that might actually repair itself faster simply because the lesion is bigger? You're recruiting more CAM proteins and all the rest of that nonsense that gets into neurochemistry.
Very good. We're running out of time, so I'm just going to give the last word to Dr. Strand here, and then we're going to have to go into halftime. Dr. Strand?
I would say that is highly speculative, not impossible, but very speculative and deserves more research. I would just point again to the best that we can do, which was a consensus guideline published last year with the experts in our field that agreed that a large lesion was useful. And I think it's important to point out we're not just talking about size, although I think the size does matter. We're also talking about shape. It's the point past the distal tip of the needle where you have an ablation, where that doesn't traditionally lesion with a traditional RF probe. So not only are we talking about a larger cubic mass of the lesion, but we're also talking more distal lesion to the tip of the probe, which I think is very important as well.
Kaz, do we have a winner?
I think we are the winners because we learned so much about radiofrequency ablation and all the new techniques here. I would say this is a tie. What do you say, Stan?
Oh, I agree with you 100%. I give kudos to both Natalie and Mark. Thanks for participating. Thanks, Kaz.
It's my pleasure. And now we go into halftime. We don't have Dr. Dre and Snoop, but we have Dr. Deere, who's just one letter away, and Dr. Syed.
So great debate. I think that my favorite part of that debate was when Kaz said he was a simple country doctor or simple little small town doctor. So
Community.
I know you well, my friend. So for the last several years, many of you have helped us raise hundreds of thousands of dollars for different charities, Ironman Foundation, Iron Aid, which I've raised for years, Make-A-Wish and other charities throughout the country and some international. So this year we continue that tradition of raising money for a charity. This is Iron Aid, which is this year dedicated to children's health and programs to help children around the country to have better health care. So there's a 90-second video, and then Dave Dickerson, our colleague from Chicago, who's going to be debating in the third quarter, will come out and give us a fiddle solo as our halftime event, since we're not big rap fans. This is our answer to the halftime show on Sunday. And there'll be a 90-second video, and then Dr. Dickerson and I were in Nashville together at the George Jones Museum, and someone said, hey, any of you amateurs want to take a go with the fiddle? And Dave looked over and said, hold my beer. And he was on the stage playing the fiddle. That's how I learned Dave Dickerson was such a great artist. So the video, and then Dr. Dickerson, take it away after the video.
We are back. In 2021, over 3,200 athletes from around the world raced in support of the Ironman Foundation. In April, athletes towed the line in Galveston, Texas. And efforts to race for more didn't stop until we crossed the finish line in December in Haines City, Florida. Through your commitment and determination, you made it to race day, and together, we provided over $2.1 million in charitable give-back across our race communities. That impact ranged from volunteer and community grants that local charities and organizations depend on every year, to programs like Race for Change, the Gold Star Initiative, IronAid, and We've Got Your Backpack. In 2021, the Ironman Foundation kicked off its Race for Change initiative, aimed at breaking down barriers for Black and other diverse athlete groups in triathlon. At Ironman Tulsa, we partnered with the local YMCA, Boys and Girls Club, and Black Moon Collective to provide swim lessons, bikes, and an inspirational mural for community members. From there, the Ironman Foundation headed to the inaugural Ironman 70.3 Memphis to team up with Major Taylor Bicycle Club, Douglas Park Community Center, and the Memphis area YMCA to provide swim lessons, bikes, and bike safety instruction. Students from Stax Music Academy created a Race for Change theme song and performed it for Ironman athletes. Through the Gold Star Initiative, the Ironman Foundation honors our veteran military athletes. In 2021, veteran athletes carried the American flag through the run portion of the race, paying tribute to local Gold Star families and their fallen soldier. Athletes and supporters joined us in Ironman Village at select 2021 races to donate non-perishable food items for local food pantries through IronAid Food Drive, and pack over 300 backpacks full of school supplies to give to local students in different race communities. Through Kahiau Together, Ironman staff help feed the island of Hawaii community, home of the Ironman World Championship, by hosting 12 food aid station drive-through events. Together, they distributed 6,200 food bundles of locally sourced proteins, fruits, vegetables, and starches, providing over 92,000 meals to local community members in need. Ironman Foundation athletes not only race, but leave their community better than when they arrived. Thank you to all of you that raced and supported us in 2021. 2022 is going to be even better, and we cannot wait to see you at the start line. Join us in 2022 and race for more.
Again, thank you all for watching that short video. That a little bar you can scan your phone on if you have any interest in helping us raise funds for that cause. And I think that's going to flip up on the next slide here. And then I think Dr. Dickerson, there it is. So if you just scan your phone there, it'll take you to that website to consider a donation. We're about $26,000 into a $40,000 goal right now. So that would be our goal for this round of fundraising for this year, to go directly to IronAid to help children's health causes. Next slide, please. And then we also were going to bring Dr. Dickerson on now. Dave, I'll give you the floor, my friend.
Thanks so much, Dr. Deere, and thanks to everyone for taking time out of your evening to come together for these great debates. Pleasure to get to provide some entertainment. So I'm going to play a little bit of Americana music, a little bit of fiddle. There's a number in there that is for Dr. Deere as well. Thank you.
All right, that was amazing. Thank you so much. That was that's what I call a halftime show right there. Eminem, Dre, Snoop have nothing.
Amazing.
Dave. That was great.
Amazing. Great
So,
job.
Elwood, you can sing now before we go to the second half. You want to sing a song or anything?
Oh man, I can't.
So we've got
That's how I was feeling when the Bills lost to the Chiefs.
Oh man, that was. That's
so
awesome.
there's also an education survey here, so you can click on that if you're a fellow for really education of drug delivery that Dr. Peterson's running. So you see that, and we'll go to the next slide. I think we have a discussion with Dr. Peterson and Dr. Chakravarthy coming to join Dawood and I. So first half.
Let me underscore that's part of our poster to podium program there, and that's Dr. Amar Mahmood is doing that as his research project, and so anybody who can click through, there's also a link on the website for that. But we really want to have a great response rate. Last time I checked, the response rate was about 19%. But what we want to know is how much experience people actually get in doing pumps during their training. And those results will be presented during Dr. Mahmood's presentation during the summer meeting in July, which, by the way, people should be looking forward to attending the meeting in July, right, Dr. Deere?
Absolutely, John. 14th through the 17th in South Beach, Cadaver Labs, all the minimally invasive procedures, and poster to podium program, our scientific abstracts and scientific presentations, and as well as our panel format as well. So should be great. First half, Erica, what'd you think? What was your thoughts?
You know, I think this is really great. It's wonderful to have the back and forth discussion. I think the most important part of this is the opportunity to hear not just some of the talking bullet points that we hear in a presentation, but really to have the point counterpoint. And that's something I think is really important when we start talking about things that are at this border zone between what I do as a neurosurgeon and what can be done in the world of interventional pain. And I know we've had some discussions about that, about where this line is of minimally invasive spine procedures. And so I and my colleagues in spine surgery really want to work to understand better how we can dovetail into this world and actually support patients who need minimally accessed procedures that help to get the results that we're looking for with the least risk and morbidity possible. And I think we really underscored that.
No, those are great points, Eric. I think that's so well spoken and a continuing discussion we all need to have. Chris, you made some forecasts before you started. Who do you think won the debates?
I mean, Florida came through a little bit, man, out of nowhere with Cleveland. I thought Ajay did a great job. First of all, I want to all four of the folks that debated. It's so difficult in the current climate, and I think the best approach to using evidence-based and science and clinical, your own judgment and anecdotal evidence. I think you guys did a fantastic job citing the literature. I was going to say the other part of this is I'm not sure. It came out a bit of a tie. I think Dave knocked it out of the park in the halftime reports. It's going to be a really interesting second half. I'm going to still go with Sheth and Beal to take it home, and I think I'm going to probably be right. Hopefully not like the same way the Bills lost to the Chiefs. So we'll see how this goes.
No, I don't think either one of those folks will have bad coaching like the Bills had in the
come on, it was close.
Dalwood, you want to give your thoughts and take it to the third quarter?
Yeah, so I mean, I think when you look at those first two quarters, I think it's really kind of why it really just is the spirit of Aspen. It's the society that it's the society of the people that are doing all the clinical work on their patients. So, those two first quarters are things that I deal with on a weekly basis. Like, should I be doing a mild procedure? Should I be putting in a spacer? Should I be using something like a Nimbus needle? Should I be using a standard needle when I'm doing a radiofrequency ablation? But I think, when you look at the first quarter, Dr. Escobar and Dr. Antony both made, really great points, where Dr. Escobar kind of said, if someone has ligamentum flavum hypertrophy, just treat them mild front line. Dr. Antony kind of taking the viewpoint of, really sit down and think about the spinal stenosis, characterize it a little bit better. Is it just central canal stenosis? Is it lateral recess stenosis? Is it foraminal stenosis? So I think, that it's really going to speak to, and I don't think either of them were right or wrong. They were both right. So I think really what's going to happen in the future, and I can probably maybe making a prediction that maybe next year's debate, we're going to be talking more about combination therapy, something that I've done in my practice now, where you do something like a minimally invasive decompression with something like a spacer or a minimally invasive fusion technique. So I think that really speaks to where I think this field is going. And we have neurosurgeons like Erica that are going to help us lead the way in doing that in a safe and effective manner. So I'm really looking forward to the third and fourth quarters. So we'll jump into it.
All right, let's take it to the third quarter now. Dr. Pope, I think you're taking over as the moderator, my friend.
Yes, sir. Thank you. And what a wonderful game so far. And halftime show, Dave, you did an excellent job. That's wonderful. As we talk about this game and we're talking about surgical approaches to treat something that radiofrequency used to treat, I think sacroiliac joint treatments, specifically fusion, is a critical component to the patient care pathway. And we're looking at posterior approaches, whether it's 2 points versus a centrally placed graft. I'm going to turn it over to my friend and colleague, Dr. Beal, to get started. You'll have 3 minutes for your opening argument. Dr. Henn, you'll then follow for 3 minutes, and then we'll do a 1-minute rebuttal, and then we'll have some time for questions. I am sorely not accompanied by Dr. Weisbein today. She had a flight diversion, and so I'll be managing the question and answer. So Doug, the floor is yours.
Thank you, Jason. Good to be with you guys. So Doug Beal, I'm an interventional radiologist from Oklahoma City, and I'd like to talk to you today about what it's not. What it is in the upper left-hand corner of your screen. But what SI joint fusion is not, it's not about fusing at one single level. What this is it's not about posterior versus lateral versus posterolateral. So I initially was trained in the lateral technique. I do posterolateral, I do posterior to anterior. So it's been shown, and I'm going to quote this paper in the future, the Jokar study in 2020. It's 55 cadaveric studies. And so the data from all of these 55 as a meta-analogous amalgam says, and I'm a bottom line first guy, so let me give it to you first. So it says that the debate is not between 1 or 2 levels. The debate is between 2 or 3 points of fixation or points of fusion. And so the best fusion happens at S1 and S2. The worst fusion happens at 1 device fixation point at S2. And the intermediate is 2 devices at S1. So the optimal number is at least 2 points fixed at S1 and S2, regardless of whether it's posterior to anterior or lateral based fusion. So some of the evidence behind this, there's level 4 evidence for a single point of fixation, and it's very loose level 4 evidence. And there's small cadaveric studies that support that. So the studies that support 2 or 3, and the predominant portion of this is 3 points of fusion, are 2 randomized control trials, 1 prospective cohort trial, 1 pooled analysis, 4 comparative effectiveness studies, and 18 retrospective studies, all showing clinical benefit. So as we keep in mind, based on the consensus statement from the CNS AANS, also joined by the AAOS, is that we have to mind our fixation and our fusion. So that statement said only spine surgeons should be doing spine fusion. And we have to mind ourselves, if we're going to be doing fusion, we need to be doing it to the maximum point of effectiveness. And fusion really is trabecular bone, and it's gained trabecular bone is assessed by multi-slice CT showing trabecular bone throughout. And it's not fixation. A lot of what we focus on is fixation. And the fixation here needs to be in at least 2 and probably 3 levels, not in the single level fixed in the center portion of the sacrum. It needs to be, the optimal level is S1 and S2 as far from the center of rotation, that means nutation, counter-nutation of the sacrum as possible.
Doug, thank you. Very well said and wonderful argument. Dr. Hinn.
Thanks, Jason, and thanks, Doug, and I appreciate the moderators and Aspen, et cetera. So I was asked to speak on single point of fixation. Full disclosure, I'm a neurosurgeon, spine surgeon. I have a slide up. I'm going to use a few slides. I'm going to talk specifically about PainTech Link. There's lots of systems. I've also been trained on the lateral and several posterior systems. This is the one I use. It's the one that has some nice data. I do appreciate that both CornerLock and PainTech have done a nice job of trying to advance the field, and that's important really to protect the opportunity to provide this care for our patients. So for me, it's all about data. Let's go to the next slide. So some nice talk by Dr. Beal about biomechanics, and bottom line, good news, PainTech has done the work for us. So this was an excellent study where they actually compared the biomechanics of the single implant link system versus what was considered or is considered the gold standard, to their credit, the SI bone. You all know it, the big lateral 3 metal, I guess, bolts that go through the SI joint. And if you look at this in each degree of rotation, it turns out the single implant system was actually biomechanically stronger than, as strong or stronger than lateral. Next slide. How's that possible? Well, I appreciate Dr. Beal mentioning the center of rotation. So this is a beautiful example of, so if you move the center of rotation to one spot, in this case, in the center of the SI joint, and how do you accomplish that? By putting your graft there in ligament ataxis. That turns out to be an incredibly elegant solution. And the reason for that is the center of rotation is where you have the least motion. So you now have fixation and no motion. Bottom line, as a spine surgeon, that's how you get fusion. Next slide, please. So I mentioned I've been doing fusions for about, or I didn't mention, but I've been doing for about 25 years. So we've had a little bit of chance to learn about this. We believe in this case, the real elegance is we're really restoring the normal anatomy by putting the single large graft with the large graft window into the center. You're getting the ligament ataxis shown in the top level, and of course, controlling each of the different axes of rotation. Next slide. So even more important than biomechanics, I'm a huge biomechanics guy. I'm an electrical engineer by background, neurosurgeon by practice now. They did a nice study. So PainTech basically said, does it work? They ended up doing a single arm multi-center prospective study. The only reason they didn't do dual arm, they able to compare their cohort with the previous lateral studies fusion or conservative group, and basically not have to put those patients through a non-optimal treatment. And next slide, please. Bottom line, it works. And so here we have 3, 6, and 12-month data using the link system. Most of the information in the middle there at this point, basically equivalent to the lateral system, 70% of patients greater than or equal to 20. Next slide. Bottom line, the lowest part, not a single adverse event, whereas in the lateral approach, 15% adverse events. So bottom line, it works biomechanically and clinically. Thank you. Go back a couple slides if you could. There you go. There you go.
Dr. Hen, thanks. Doug, you have a minute to rebut. You're muted.
Sure do. It's not a matter of whether it works. You know, the posterior fusion clearly works. It clearly works, and I said that from the very outset. It's just that compared to the single study that Dr. Hen put up, we've got 55 studies, and the meta-analysis has said not only is the center of rotation not where you should put the implant, you should put it as far away from the center of rotation as possible, the center of nutation and counter nutation. And it's not a matter of limiting the rotation, because both techniques do. It's a matter of gaining fusion and stabilizing to the greatest degree. So if you look at what stabilizes a joint over time, the data is very clear as compared to the level 2 evidence that Dr. Hen put up. We have Insight and IMEA, the 2 level 1 studies, as well as this level 2 study, the Sci-Fi study. We've got data from Cross, another level 1 study, and then Vanaclocha data. We've got 3 different meta-analyses, and we've got lots of data saying exactly opposite of that, that we shouldn't have something at the center of rotation. We should have it as far away from that as possible.
Dr. Hen.
Next slide, please. So bottom line, I kind of disagree humbly that when you said it doesn't matter if it works, the bottom line, that's the only thing that matters. And I guess that's one of those things where sometimes you have to go back and figure out why the study doesn't seem to match up with the actual clinical experience. So what we can say for certain, that bottom line, the PainTech link system is biomechanically at least as good as, or perhaps maybe even better than, what we'll call the gold standard. I'm a huge fan of the IMEA study. I think they did a great job. The only reason I don't do that technique is because I find it very morbid. So that's my own bias. The implant, the one implant PainTech link system is clinically proven, and that's through this prospective multi-center trial. So we're actually out to 12 months, but we've got 6 months, the same amount of data as the IMEA study. And then bottom line, I think you could make a case that maybe the link is actually the new gold standard. Then it just becomes a question of common sense. If a one incision, one implant system works, why would anyone possibly want a second incision, second implant? I think just that kind of classic, just ask a 1-year-old, would you rather have 1 incision or 2? Next slide. Obviously having a little bit of fun here. I think we agree on that. And then the final slide. I think truthfully, if you asked PainTech, they probably would advocate for the 9 implant system. It turns out that's probably the most effective way to fuse the joint. But I think what this studies have shown is probably not necessary.
Dr. Hen, thank you. And I want to field some questions from the audience, and I have some prepared. And when we talk about the innovative space that a posterior approach is, when we have innovative therapies, there is a paucity of data. That's because they're innovative. And so I do commend the work where we want to try to acquire prospective data on a posterior approach. And full disclosure, as defined in the slide, I'm the principal investigator along with Dawood Syed for the prospective single arm multi-center study looking at a single approach. But the question that I have is in regards to the need for prospective data. So it's funny because we hear a lot about, does the data matter? You can cut the data a lot of different ways. Does the statistical significance or superiority or non-inferiority really matter? How do clinicians really determine what they're reaching for? Is the degree of and location of fusion, does it matter clinically? And so to ask this question, I'll ask Doug first, and then I'll ask Jeffrey. If you were introducing a posterior approach, whether it's a single level or two level point fusion, how far would you have to follow out prospective data? Or firstly, do you need prospective data? And then secondly, how far would you have to follow them out to be impactful for our space?
Yeah, so the main objections I have to Dr. Hinn's presentation is he doesn't have any data that has any length of durability at all. And there's been lots of length of durability at multi-point fixation. And we do know that a cortical dowel placed, and this is from AO principles and the orthopedic literature, that if you place a cortical dowel, it softens up over time. And just spreading the joint across, you're counting on that to have trabecular bone joining from one side to the other, and you're banking on one point of fusion at that level. That's the point of rotation, the maximum point of stress and strain. And I just categorically disagree with that. I agree with prospective data, prospective acquisition, and you have to follow it out at least a couple of years, because statistically between 1 and 2 years is when that cortical dowel starts to soften up.
Yeah, maybe a minor misunderstanding, Doug, and I do appreciate, obviously that's why we all have different insights. Obviously I've gained some of my nuances from being a spine surgeon and doing a lot of fusions and having to live with the results. So I agree, important to watch this over time. I think maybe a mild misunderstanding, it's not a dowel. That's really important. So the point is a dowel, you're right, would pivot and potentially would, I'd be afraid would subside into the bone. The point is this is actually a cage. So it's actually designed to be a press fit to obviously transfix the joint. So no, absolutely good news. A year out, so far so good. Certainly that's been the case in my own clinical practice, but yeah, the problem is I don't have a way to jump forward in time other than say, so far this has been a wonderful addition to my practice. I've got a bunch of extremely happy patients to kind of rely on, and absolutely we'll live and die with the data. I think the data is critical, and good news, Pain Tech I think is doing a nice job of trying to get the data. And of course, God forbid something changes, I know they'll be incredibly ethical and present that, but so far I have no reason to think that.
And Jay's final point about Dr. N made a point about the limited amount of invasiveness there is in a small incision. I put 3 fixation points from a lateral base through 12 millimeter incision. And my posterior approaches are all done that way too, through a small incision posteriorly to anteriorly. So I don't think it's a matter, you don't have to do a large incision, a lot of dissection to do big stuff on the inside with a little incision, limited invasiveness on the outside.
Oh yeah, no, I assure you don't need to teach me about minimally invasive. That's what I do all day, every day in the spine. It's not the length of the incision, it's what you're doing on the inside. So I think, again, a 1-year-old would agree that three metal bars going through your sacrum and pelvis is more morbid than putting a spacer into the.
It also provides a better fixation.
Of course.
Well,
So far not.
To kind of highlight a little bit of the plan for this prospective data set, there is a plan to follow these patients out to 24 months. So the question originally was, how far do you have to follow these patients out clinically to change the hearts and minds, if there is hearts and minds to change? The next question that I would ask is obviously a politically charged one. There's been a lot of topics surrounding which specialty should own this sacroiliac joint fusion space. And the question that I would ask is it specialty dependent or is it skill dependent? So I'll ask Jeffrey first, and then we'll go over to Doug.
I think it's absolutely skill dependent. I've always advocated as I moved into this space that I think people with interventional training, frankly, have the perfect skill set to do this operation. I think you have to then, have at least some cross-pollination, because no question there is some benefit to be gained from having, whatever, I'll make up a number, having done 5,000 fusions in the spine, and again, lived with the good and the bad and learned things along the way. And I think there's something that can be learned from that. And so I think obviously specialty or skill set rather than specialty, in my opinion.
Doug?
Yeah, I agree. It's a skill set. I've done as many SI joint fusions as anybody, I think. And you started out learning it lateral. I do posterior lateral. I do posterior to anterior. And I've seen people, one of the things I've seen it quite a bit is is misplacement of technique. One of the mistakes I see in the posterior approach is not putting the dowel far enough anterior. But it's really more, I've seen some great fusions be done by people with interventional capabilities and vice versa there. So it's really about knowing the anatomy, knowing the landmarks, and knowing what the goal it is you're trying to accomplish.
Very good. Okay. Well, I'm going to hand it back to our awesome moderators. I thought that was a really good third quarter. I'd like to see the fourth quarter try to beat that one. Tim?
Wow, that was a great one. That's why I come to the Super Bowl, to see things like that. That was a great discussion, gentlemen. Wow, man, that was great. So now in the fourth quarter, I just feel kind of sorry for Rick Patience and Ken Chapman trying to get the level of discussion going with our panelists. So Dr. Patience, Dr. Chapman, it's all yours. Good luck with that.
Thank you, Tim Deere, and the rest of the Aspen people here on this call. This is Ken Chapman, and we're really excited to be closing out this fourth quarter. I think we've learned a lot. I think what everyone's done is got people thinking, and I'd like to take this time to introduce our speakers, what they're going to talk about, and that's really the use of Sprint PNS, either before RFA or after RFA. Rick, you want to introduce Dr. Sheth?
Hey, great. Thanks, Ken. Yeah, that was previous discussion's been great, but there's no reason that we can't augment this discussion because there's a lot of issues revolving around this topic in general. And before I introduce Samir, in the groundwork, I guess we're going to assume that we're dealing with patients who don't have spinal stenosis, who don't have an unstable spondy, and whether the question or not of paraspinous muscle atrophy is involved or not. And I think, ideally, this session would have included the mainstay restore equipment as well. So I'll start off. Ken, want me to introduce Samir now?
Sure.
Samir Sheth is up in Sacramento area. He originally did anesthesia in Columbia, then went to UC Davis, where he trained under Paul Crease, who's a dear friend of mine, and completed his pain fellowship, was on staff there for about 8 years, and now he's in private practice at Sutter. And besides those previous questions that I just brought up, did Dr. Crease ever tell you about his hot tub stories in residency? That would be the most interesting part of this discussion. Samir?
No, but I think you can tell me if you want.
I would be killed if I told you.
Okay. No, he did not. So.
And Ken, you want to introduce David?
Sure, I'd love to introduce David. David is, I'm excited to have him coming up and closing it out for us. I think, he's the ringer that we saved for last on Team Blue over here. He's trained in anesthesia at the University of Chicago, went on to UCSF for his pain fellowship, back to University of Chicago for 5 years, and now he's a section chief of pain medicine at North Shore University Health Systems and a clinical associate professor at the University of Chicago. Dave Dickerson is going to represent. He is the self-proclaimed S1 DRG Lord, for those that don't know. Very passionate about that for Raymond. And one thing, and it's great to have you on here and see you again, buddy. So we're going to get this started here. And what I think I enjoyed most about this so far is that this really got people thinking, thinking how to practice in ways differently than they walk into a scenario thinking that the decision they're going to make. And, when I look at Sprint PNS, at being an older guy in the game at this point, maybe I'm more cautious, I don't know, but in my opinion, I do RFA first. And if it failed, then I'd try PNS. Samir Sheth, why don't you change my mind?
Well, thanks, Dr. Chapman. I appreciate the time here. And I actually, just like you, I felt the same way for many years about, about RFA versus Sprint and when to use it. And I think the first couple of cases I did kind of change my mind, but more to that, I mean, that's a personal opinion. But when we look at it and why are we deciding when to use this device or this treatment or this therapy, I look at it from a variety of different ways. And I think the first thing is mechanism. Does a mechanism make sense? And I think and we can't dive too deep into mechanism today because I only have 2 minutes and 31 seconds left, but there is a great paper by Dr. Deere and his colleagues describing cortical reorganization with healthy efferent stimulation via using this temporary peripheral nerve stimulation device. And I think that there is a ground for this to work, and it has shown to be effective. Then there's also the safety aspect. So is it safe? And yes, it is. It's been shown to be, from when I do this procedure, I can do it in under, I don't know, 5 to 10 minutes, and the flow time is very, very low. And also it gives you the opportunity, if you feel comfortable, you can do it under ultrasound and avoid fluoroscopy altogether. The risk of infection is very low as well, about 0.1% across the board, and then also any really low risk of nerve injury. So I guess if you're doing an RFA technique, and although I will say that RFA is obviously very safe as well, there is a chance for a greater chance of nerve injury. So I think that's something to look at when you're looking at from a safety perspective. And then we want to look at the evidence. So is there evidence to support the use of temporary PNS before RFA? And I think Gilmore and Desai and his colleagues did a paper in 2021 that did look at and examined at least a smaller, population, but it was a very meaningful population of patients in which 51 out of the 74 patients achieved a clinically significant outcome and really good benefit from this procedure that was sustained over about 8 to 12 months, if I remember correctly. And then also Dr. Pingree out of Mayo did a real world study, which looked at, is this something, when you look back retrospectively, about 324 patients. And that was in fact the same thing. About 70% of patients received about 8 months or more long-term relief with this temporary therapy. And then finally, in this time that I have, I think what we need to look at is a patient-centric approach. Now, we all know that RFA is effective and it works, but we can't deny the fact that it denervates the nerve, and it also denervates the multifida. It reduces the amount of stimulation in the multifidus muscle. So then we don't really know what the true effects of that are. And I think that's something to really look at when we're examining whether or not to do the sprint system before the RFA. Also, we have to look at, it may also treat other conditions other than facetogenic pain. So what we've seen in this study by Gilmore is that it also can help treat discogenic pain. It can also treat degenerative disc disease. So a lot of different types of pain. So I think that's also a reason maybe consider this as well. So I know I ran out of time, but I wanted just to say that this is something that may be used prior to RFA. Doesn't burn bridges. It's a patient-centric approach, and patients truly, it was studied also that patients do prefer this technique over RFA when given that option.
Thank you, Dr. Sheth. Dr. Dickerson, you're up.
So I agree with what Dr. Sheth has said, and I think that fits a very common practice. I think, in any sort of debate, you want to take the question that's posed in front of you. You want to craft it in a way that makes it so that you can answer the question that is going to provide an airtight argument. And I think that the challenge here is the question of sprint before. We're talking about a procedure before another procedure. We should really talk about, as you said, patient-centric approaches. Who is the patient? And we should really always leverage diagnosis-specific treatment. And it's tempting to take tools that are so effective, as you mentioned, for multiple disciplines and make them our first-line treatments because you get this high responder rate. But what does that do for us in terms of our long-term care of patients, in terms of diagnosis-specific treatment, the taxonomy, our understanding of where in the taxonomy of pain that patient is during that phase of their treatment? And I think that when we're treating facetogenic pain, and that's where I'm crafting the argument towards the discussion of, if we agree that we're treating a patient with purely facetogenic pain, I want to be able to provide something that has equity and access for all of my patients. And that's something that insurance supports across all payers for radiofrequency ablation for facetogenic pain. Of course, there's hoops to jump through, and there are some non-patient centered aspects of this that we have to follow through in terms of multiple trips to our office. And I would say that those are things that we have to ask our patients for. But when we have a patient that we believe has facetogenic pain, a radiofrequency ablation is a tried and true treatment for that. That's highly evidence-based, supported by all payers. And one of my challenges with the SPR peripheral nerve stimulation studies are a lot of those patients in Dr. Gilmore's largest studies looking at axial back pain, 67% of those patients were not Medicare aged. But those are all patients that I'm going to have a hard time getting peripheral nerve stimulation covered for facetogenic pain. So now I need to diagnose them with neuropathic pain. And maybe they have that too, but what's a great way for me to tease that out? To treat their facets. And then if they don't respond, which with the number needed to treat being somewhere around 2 for facet denervation, 1 or 2 of those patients are going to have response to the facet diagnostic treatment that led to them being a candidate for RFA. They're going to get their RFA and maybe they don't get the results they're looking for. That's the patient then that I'm going to say had a mixed picture. They're nociplastic, they're neuropathic. And then I'm going to deploy my armamentarium for that diagnosis, like peripheral nerve stimulation, for all of the great reasons that Dr. Seth laid out, because it is a Swiss Army knife for that mixed bucket, that mixed picture of those patients that always confuse us of, it was a home run RFA. It did the same way I always do it. It's really straightforward. Why don't you have relief? Well, I do think that that's exactly where a tool like percutaneous peripheral nerve stimulation at the medial branches makes a lot of sense.
Awesome. Thank you, David. So Samir, you make a great argument for PNS system in degenerative back disease, not only treating potentially facetogenic, but also discogenic pain that may be treated well with this procedure. David brings up an interesting point about insurance coverage. And I think that, one of the things that we have to address is, we always talking about costs. And if you can get someone authorized for this, and also if you can talk them into it. When I look at neuromodulation in general, I always start early on in my conversation, so we may use electricity, Then when it comes down to actually doing some type of neuromodulation, they've been prepped in going forward. So to jump into PNS, I wonder about the acceptance of this. So I'll pose that question to you, Samir, is what's the acceptance rate and what is the authorization like for you with your approach?
Well, first of all, I think Dr. Page, I'll get to that in a second, but David brings up some really good points. And I think that when we look at, I agree, I think that I'm not really fond of having this non-specific diagnosis. I do see that when we look back at our people and our patients that have done well, there is a wide variety. And I think we need to really delve deeper into that. So I think that's a very good point that we need to say, because we want to be very specific with our diagnosis and understanding what we're treating. We want to be nuanced with our treatment. And I think hopefully over time, we'll be able to discover that. I am not a huge fan of insurance companies dictating what I want to do. So if I have a 40-year-old patient and then my only opportunity is to do a radiofrequency ablation on that patient, what am I going to do next year or the year after or the year after? I find that to be a horrible way, and I will fight tooth and nail for those patients, because I just don't think that's appropriate, especially when you see something as, let's say, forgiving as peripheral nerve stimulation or non-destructive. And to your point, Dr. Pacious, with regards to the conversation, I honestly say, I've done so many of these. I feel like, this is something I would easily offer to my family members, to my parents, to my brother, whatever, because I do believe in its safety, and I do believe that the temporary aspect of it does allow me to tell them that, hey, listen, if it doesn't work, we can remove it and then we can move on. That is something I use to my advantage, and I have early discussions with them as well.
Got it. David, your response to his argument.
Yeah, I think there's a lot of, it's a little bit of a black box for us. I don't think we really understand. I think I've been hearing, depending on who I rotated with as a fellow 10 years ago, I'd go do a dozen ablations over the course of a week. And then the next week, the physiatrist would pretty much tell me that I'm pretty much crippling these patients. And then we'd see high level RCTs that show that patients' functional outcomes improve significantly with RF plus PT versus just PT. So I really think that the multifidi muscle is a highly controversial structure in regards to its real role outside of high performance athletes in terms of the real role of that. Now, the idea that maybe a denervated multifidi is a separate pain generator, again, we just don't know. And I think that would be another really interesting study for us to start to really appreciate, with doing things like you do the denervation, and if the multifidi is causing the pain, go back and do another diagnostic. We really have to sort this out. I think we have a lot of great narratives here, but without the data, without the real understanding of this as I think we also have to be careful not to cannibalize ourselves talking about harm associated with our bread and butter evidence-based procedures.
Samir, I'll give you the last word.
Well, we're just going to jump. We're just going to jump in and wrap this up. It's a 2-minute warning, and when I say that, I don't mean that you guys can only debate for 2 minutes. I mean we're literally going to get cut off the air in 2 minutes. So 30 seconds each. Yeah. No offense. We're going to ask you guys questions. Samir, cost effectiveness.
You know, I think I think we need a study like we were talking about. Within, I think Sprint right now, I just involved in a study that they're doing Sprint versus conventional medical management. So we're going to find that out. And I think Dr. Dickerson and I agree that we just need much more data. And I am not going to, speak to, I think the RFA still has its place. And I'm really, I use it for many of my patients. I just want to be cautious and offer patients options. And so that is my goal. So that's my 30 seconds. Dr. Dickerson.
I fully embrace the evolution of our evidence basis and technique, and I do find that the sequence of being able to provide procedures to the right treatment to the right patient at the right time is at the heart of this discussion. That mixed picture patient, we've seen magical things with PNS, but I do think if it's clearly facetogenic, I don't think we should cannibalize radiofrequency ablation just to promote what we're excited about for many other patients.
Excellent. I think we got one more second here, Tim, or we are?
Oh, no, you're good.
So I think the as I said in the preamble, we should have included the restore from mainstay in this discussion because it's right in this bandwidth. And I know that right now getting authorization for that is challenging. And if we'd included that, I think it would have been a much more robust discussion. But both of you guys did a great job and I appreciate your time.
Thank you, guys.
Well, there you have it. There's the fourth quarter. Wow, that was a great night. I'll have my colleagues join me for the final wrap up, the last few moments of analysis. Dr. Peterson, let's start with you. What was your analysis? Can you give us some highlights of what you really stood out in your mind tonight?
Well, I have to say that not only was there great, vivid passion, but really backed up with evidence and expertise. That's one of the things that I think makes these debates valuable here is it's not just somebody saying in my opinion, but we actually have people able to go to the literature and hopefully refer all of our participants and observers to go learn that literature for themselves. That's what's going to help us make sure that we maintain that access that Dr. Seth was talking about for our patients. And we need to write an appeal. We need that literature.
Wonderful points. Krish, you have any superstars in your mind tonight? Some quotes that sticks out?
Yeah, no, I think everyone did a fantastic job. But, the one takeaway, and I would encourage all of the people listening is, the studies that industry or what you decide to do is something that physicians should be driving. And one of the big challenges our space is coming to is that as you get more and more options, I've said this before, comparator trials are the way a lot of medical fields move forward. So how do you design the trials to get the outcomes? What groups you're really wanting to compare is really critical for an indication, right? And tomorrow, as each year ticks by and you're getting more and more options for spinal stenosis, you're getting more and more options for mechanical back pain, the level of evidence and the way that most clinicians think about anything is how do you compare one treatment to another? So I think our space is definitely going to get to that point where I think the emphasis on better trial design, looking at different therapies, one versus another is really going to answer some of the more specific questions that we're asking.
I love the comparative thought. I think that's where we're going to end up eventually. Darwin?
I think the big takeaway point here is that anytime the debaters can reference the moderator's studies, so Jeff Henn referenced my biomechanical sacroiliac study, that really makes you stand out. Sam or Seth, referenced your mechanism of action, peripheral nerve stimulation. That's really going to make you a winner. So if you can reference our papers in your debate, you really got a leg up. So those are really the true winners. But all kidding aside, I think this is really excellent to see. I learned so much, just seeing things from an intervention interventional radiologist like Dr. Beal, who's published 1 billion papers and has so much experience. And then, you know, a minimally invasive neurosurgeon like Jeff Henn that does, you know, big spine surgeries and minimally invasive surgery, to talk about something like SI fusion that, you know, probably more pain physicians do than anything. So I think it's really interesting to hear these different perspectives. And I think, you know, similar with, you know, peripheral nerve stimulation and radiofrequency ablation we saw in the fourth quarter, another really great debate. So I think, you know, it's showing where kind of our field together is going. It's really not a single specialty, it's multiple specialties moving together. And that's why ASPN is what it is. It's not just a pain society, it's a pain and neuroscience society, it's a surgical society. When we all work together, we're really going to push the needle forward for our patients. And that's what these debates represent.
Yeah, I have a final thought, then Dawood will take us home with the last 2 slides. My final thought is that these debates used to be very confrontational, but now they're much more collegial because data is bringing us together. You know, we're using data to bring us together. And I think that's part of what Eric is doing with the Poster to Podium plan. That's what ASPN is doing in society. We're using data and science to motivate the field. And you know, I think that's where we're going to be. So I think hopefully that'll continue to come closer together as we become evidence-based in our practice around the world and around the United States. But that, Dawood, I think we have 2 final slides you can show and we'll call it a night.
Yeah, so, you know, we're going to have another debate in late March, March 22nd. So be on the look for that. And then let's go to the next slide. And then I think I'm really excited about this. This is our think tank, March 12th in Nashville, Tennessee. So we really have, you know, about 13 to 15 different topics that it's going to be a, you know, it's a meeting like no other. It's a very intimate meeting. You know, we'll probably have very limited seating. So, you know, we still have some limited spots left for physician attendees, but we like to have a smaller group. It's open discussions. We're going to have, you know, established companies in the space presenting new and novel ideas. We're going to have a lot of startups talking about some of their new ideas. And we're going to have a lot of ASPN type discussions that are really going to be non-sponsored. So I think it's really going to be a unique meeting like no other. I think it's going to be limited in space. So, you know, hopefully those of you that want to get in, you can get in. I think we have a few rooms left. It's going to be at the Virgin Hotel in Nashville, Tennessee, a great location as well as always. So looking forward to having everyone out there with us in March. And with that, last and final, we'll have our ASPN annual meeting July 14th through the 17th, 2022, of course, in the Lowe's, Miami South Beach. So looking forward to having everyone there as well. So thank you everyone for your attention tonight, and we'll see you at the next opportunity.